Hi, everybody. Welcome to our free webinar today. So excited to have you for about a half an hour to talk about sepsis. First of all, I just to kind of orient us, this is a quick free webinar. So we will break down as much of sepsis as we can. I think we'll be able to get to a point where we start to feel a lot better about it if you're not feeling great about it right now. Couple questions to kick things off. How do we feel about sepsis? I feel like sepsis is one of those things you either love it or you hate it or it just doesn't click yet. It's one of those concepts that might take a little bit of time, might take hearing it a few times for it to really click and sink in. Where are we at? If you guys want to use the chat, um, tell me on a scale of 1 to 5, how confident do you feel about sepsis? 5 being the most confident. And that way I can kind of see how we're doing. Okay, we're a bit all over the board. I think I've seen every single number, but I'm seeing a lot of threes, a lot of twos and threes. Um, that's not a bad place to be. I hope we can get to maybe even a 4 or a 5 by the end of today. My goal is that you will understand how a normal infection gets to sepsis, and then that progression of why we get so concerned about sepsis and it turning into what? What is our big fear with sepsis? What do we want to avoid it turning into? What can it progress into might be a better term. Perfect, Vanessa. Yeah, septic shock. We are really concerned about septic shock. Somebody else put in, Danielle put in DIC. I love that answer. We're also concerned about sepsis causing DIC, and we'll talk about how it does that as well. So, sepsis for me, I just introduced myself a little bit in case this is your first time seeing me. My name's Rebecca. I've been with Archer for the last couple years. I should have that a little bit more dialed in, but I think it's been around 2 years. And I work primarily in the professional education space. So after graduation, when you're working as a bedside nurse and maybe you're thinking about getting a certification like the critical care nurse certification, I work a lot with those learners. And I love critical care. That's my absolute niche. It's my favorite thing. And I see so much sepsis in critical care. In fact, I worked this weekend and we had plenty of patients on the unit in sepsis and septic shock. And I am so excited to walk through how we handle that and how we recognize it. And again, how we go from just a normal infection to sepsis to septic shock. That progression, I think if you can really wrap your head around it, will make things make so much more sense. And then when you're bedside with your patient, you will see some of these signs and feel a lot more comfortable taking care of them. As well as, obviously, when you're taking your NCLEX, recognizing those signs and symptoms of sepsis is super important. Okay, so before we start diving into content, we're going to dive into content, but before we get to my first slide, can someone tell me what is like the foundation of sepsis? What's present in the body when we're worried about sepsis? Great. There is nothing that makes me happier than when I ask a question a really weird way and you guys totally understand what I'm looking for with your answers. So thank you so much. Everyone's saying infection, and that's exactly right. With sepsis, we are concerned about an infection. Infection has to be present for us to be calling it sepsis. Now, where typically is this infection located? Might have started one place, but now where is it located? Yeah, the bloodstream. It's a systemic infection. A lot of times it's in the bloodstream. Either way, it's affecting the body systemically. So let's talk about this pathophysiology. Now, if you have not heard a lecture of mine before, then good news for you because this won't be the 50th time that you have heard this. But if you have heard lectures from me before and you've heard me talk about inflammation at any given time, then you have heard me break down inflammation into two key symptoms I want you to remember. So, inflammation is our body's response to infection, right? It's our body's first response to that infection. Can somebody give me some symptoms for infection? And inflammation, really. Inflammation's really what I am getting at. Okay. Yep. I'm seeing fever, tachycardia, swelling, warmth, redness. I love that. Warm to the touch, high white blood cell count. Awesome. Okay. So let's focus in on that warmth and redness. When we see warmth and redness, are we typically talking then about a localized inflammation? Let's say somebody's got a cut on their arm and their body's having that inflammatory response. We might see that localized inflammation, and that's where we look and we see, oh, yeah, it's warm, it's red. What does that mean is happening on the cellular level? What gets us to that warmth and redness that's happening in a localized area? Yeah, y'all are great. It's vasodilation. One of the properties of inflammation, one of the symptoms and the what's happening during inflammation is we're trying to get more blood to that area because it's packed with all those white blood cells to help fight that infection, help handle those foreign bacteria that are now trying to invade. So if we vasodilate, we can get more blood to that area. Now, there's something else that's happening with swelling. So we've got vasodilation with inflammation. What other thing is happening that's leading to swelling? Again, more on the cellular vascular level. Yeah, we've got histamines being released that's causing some of this. Edema is happening. Edema is happening because we have something called increased capillary permeability. All right, I'm now going to flip us to our slide. Now that we've kind of talked through this, because this is kind of a wordy slide, so I kind of wanted to orient us first, and you guys are doing a great job. So, what we're talking about here is inflammation. And we talked about how when we are fighting a localized infection, our body is going to vasodilate in that area to bring more blood and more support to that area. It's also going to have something called increased capillary permeability, which is going to allow for fluid to seep into the tissues, get those white blood cells into the tissues to fight in that tissue infection. And that's where we get that warmth and redness from. Those are all signs of inflammation. And it works really, really well when we have a localized infection because we can get those white blood cells where we need them to go. Now, when we start to talk about sepsis and we have an infection, let's say it's pneumonia, let's say it's cellulitis, some sort of localized skin infection gets really, really deep into the skin and it starts to interact with the bloodstream. And now we've got bacteria in our bloodstream. Now we have, instead of just a localized area experiencing that inflammation response, that inflammatory response, now there's bacteria in the bloodstream, and every single cell in the body is going to be having that inflammatory response. And it's going to lead to those two main cellular symptoms I want you to think about. And I'm not talking about our visual symptoms. I'm not talking about warmth and redness. I'm talking about what's causing that warmth and redness, which is vasodilation and increased capillary permeability. In sepsis, like I said, instead of that just happening at a localized area, it's now happening everywhere. And that is why sepsis gets so dangerous. This is when inflammation goes way too far. Inflammation, if it's done right, it's really good for us. It fights an infection for us. But as soon as it gets to that systemic level and we now have cells all over the place experiencing this inflammation, we are going to cause a cascade of events that is not good. So let's break this down. Pathophysiology of sepsis. We have that infectious trigger. Could be anything. Could be pneumonia. Could be that cellulitis skin infection. UTI can cause this. Any source of infection interacts with the blood. And now we've got that systemic inflammatory response as inflammatory mediators are released everywhere. So now what are we going to see? We've got that vasodilation component. Again, not localized, it's happening everywhere. Massive venous and venous and arterial vasodilation. What is our biggest risk with massive venous and arterial vasodilation? Why would we be concerned about that? Yep. Low preload and output, hypotension, you guys. Absolutely. This is what's going to lead. When you hear vasodilation, I want you to think hypotension. We've got we're taking a tube, a hose, and we're making it really, really wide. Doesn't matter how much volume you have in that really wide tube, our pressure is going to be low. When we vasoconstrict and make that tube really, really small, that's when we raise our blood pressure, right? So vasodilation happening everywhere is going to lower our blood pressure, and it's going to kind of keep going. When we've got that increased capillary permeability happening, that causes endothelial dysfunction. The endothelium layers of the vessel are going to start to kind of separate. That's endothelial dysfunction, increasing that permeability. That's going to cause even more inflammatory mediators to be released, one of which is nitric oxide. That's a potent vasodilator. So we're now kind of causing this cascade of events to occur over and over and over again, leading to more and more vasodilation. Now, as we continue to cause endothelium damage, that's going to impair our clotting mechanisms. Our body realizes that we've got endothelium damage and it's going to trigger our clotting cascade. And what that's going to cause is our body to make lots and lots of clots, lots and lots of little clots. Sometimes they're big clots, sometimes they're little clots, but it's going to make a ton of them. And that's when we're worried about DIC. Can someone tell me in the chat what DIC stands for? It's kind of a long name, so it might take a second to type it. Yeah, great job. Disseminated intravascular coagulopathy. Great job, or coagulation. Absolutely. So what we're seeing, the other term, there's another term for DIC that I really like because it clues me into exactly what's going on, and that's called consumptive coagulopathy. So we've caused all this endothelium damage. We are going to make lots and lots of clots, and those clots are going to use up all of our clotting factors. Our liver is responsible for making our clotting factors. We only have so many to go around, and they all play a little role in the clotting cascade. If we don't have them, then we can't make clots anymore. So this endothelium damage is going to continue. And now we're making clots and we're sending them all over the place. And now we can't make clots where we need them. So this DIC is a condition characterized by bleeding because we've used up all our clotting factors, making all these little clots everywhere. So we've got bleeding happening and we've got that clotting happening. So we can see a multitude of symptoms with DIC. We can see stroke, we can see pulmonary embolism, deep venous thrombosis, we can see renal failure because we're sending clots to our kidneys. We can send clots anywhere and occlude blood flow and perfusion anywhere. That's the clotting problem of DIC. We can also see extreme bleeding. This bleeding can occur also in the form of a stroke, hemorrhagic stroke. This can be GI bleeding. This can be really small tissue bleeding like eyes, ears, and nose. Gums can start to bleed. I've seen that with patients before because they have no clotting factors left. It's amazing how our body is kind of constantly clotting to keep certain tissues from bleeding, specifically our mucous membranes. They're put through a lot of damage. They could be bleeding all the time, but our body's kind of always taking care of that. But when we don't have clotting factors present because they've been used up, we can bleed anywhere. We've got lots of factors contributing to this DIC existing. We know that we get this endothelial dysfunction from sepsis, from this increased capillary permeability, that wall breaking down, and it leads us to DIC. Now, with all of this, we're going to lead to a final result of tissue hypoxia. Our mitochondria are going to start to dysfunction. They're not even going to take up available oxygen anymore, regardless of the supply. And we've got that hypoperfusion from vasodilation. So again, we've got this inflammatory response that for localized infections is really handy, gets white blood cells where they need to go. But when we have a systemic inflammatory response, things are going to go too far. And it's our job to recognize that, whoa, things have taken a turn. This is a systemic response. If we don't intervene, our patient might have a really low blood pressure and be at risk for death. That's where sepsis can get deadly. So, what are we going to see with our patients? First of all, risk factors, advanced age, male gender, malnutrition, comorbidities like diabetes, burns, substance abuse, malignancies. That can all lead to an increased risk of sepsis, an increased risk of a localized infection turning systemic. Clinical manifestations, y'all already said a lot of these. We can expect to see fever. We've got an infection on board. We can expect to see hypotension from our two main inflammatory symptoms going systemic. We can expect to see tachypnea into tachycardia. Why tachypnea and tachycardia? What's the justification for that? Perfect, Cass. Yeah, Faith. Perfect. It's all compensation, right? We're not perfusing. So if we're not perfusing is getting oxygen to tissues. We are going to increase the amount of oxygen we bring to the blood. So that's tachypnea. Let's breathe more. Tachycardia, we're vasodilated. Our body recognizes that, and the first thing it's going to do is tell that heart to beat faster to increase what in the setting of hypotension? What's the purpose of an increased heart rate? It's the BP, but there's one main thing that it's going to increase. Yeah, Jasleen, I'm hoping I'm saying that right. Kanisha, perfect. Cardiac output. Cardiac output stands for stroke volume times heart rate. If we increase that heart rate, we're going to increase that cardiac output and increase perfusion. Absolutely. Altered mental status, especially with our older adults, they might not show a fever, but they will be confused if they've got an infection on board. And relative hypovolemia. This means technically we haven't lost volume. This person's not peeing a ton. It's not like they're losing volume anywhere, but they're so vasodilated that we call that relative hypovolemia. For how big and wide those vessels are, they are empty, even though they technically haven't lost volume. We just call that relative hypovolemia. We're going to look at this patient. We're going to do a couple things. We're going to assess their inflammatory response, their systemic inflammatory response. We can do this by looking at something called SIRS criteria. SIRS can exist without an infection. This is just a systemic inflammatory response. We see this post-operatively sometimes. We don't always have an infection, but if we do, we would call this sepsis. So let's look at that criteria. Are we seeing hyper or hypothermia? Either one could indicate that there's inflammation happening. Heart rate over 90 and respiratory rate over 20, again, showing that we've got perfusion problems and our body's trying to compensate. And white blood cells over 12,000 or under 4,000. Again, they can be high or low, kind of depending on how that patient's fighting that infection. We also want to take a look at their organs. We know that this is systemic, right? So how are the organs behaving to kind of tell us how bad is their sepsis? So we can use a SOFA score to do this, sequential organ failure assessment. It's going to assess PaO2, how much oxygen's in the arterial blood. FiO2, how much oxygen are we giving them to get that much oxygen in the arterial blood? Are we having to mechanically ventilate them? What's their platelet count, which tells us, are we in DIC? Have we used up all our clotting factors and our platelet count is really low? Glasgow Coma Scale, how's their neurostatus? Bilirubin, how's their liver doing? MAP, perfusion related. Creatinine, how's their kidneys doing? This is looking at multiple organs to assess for how is this person responding to the sepsis. Now, lab analysis, there's so many labs we can send for sepsis. Cultures, we want to take a look at specifically blood cultures. Those are what we care about most. We know we've got a systemic infection. It's normally caused by that bloodstream infection. But where did it come from? Was this a pneumonia problem? Let's send off some sputum cultures. Was this a UTI? Urine cultures. If there's skin infections, can we culture those skin areas? We can send off blood inflammatory markers. Lactate is really common to send off. Is lactate, I should say, both of them are kind of the same. Is lactate acidotic or alkalotic in form? Yeah, it's acidotic, right? So we're going to send off a lactic acid. This is secreted. It's a byproduct of anaerobic metabolism. Well, we're probably in anaerobic metabolism if we're not perfusing our tissues. So our cells are going to make this byproduct of lactic acid, and that's going to give us a metabolic acidosis, which is dangerous within itself. Procalcitonin and CRP are really good inflammatory markers to judge overall systemic inflammation. They're not specific for inflammation occurring in one location or another. Coagulation studies. What condition, why do we care about coagulation studies that we just talked about? What risk condition are we concerned about? Yeah, we're concerned about DIC. We're concerned about our clotting factors being used up. If our clotting factors are being used up, will our INR, PT, and PTT be longer or shorter? What would we expect these labs to look like? Yeah, these are bleeding times. So I'm using that term longer versus shorter instead of higher or lower, but you could view it either way. But since they're times, yeah, we would expect them to be longer. It's going to take a lot longer for a clot to form if we don't have as many clotting factors around. D-dimer is a clot dissolution factor. So this is going to be in the bloodstream when the body's noticing there's a heavy clot burden and it's saying we got to break down some clots. We are going to see an elevated D-dimer indicating we've got a clot burden in the body. CBC and CMP are just good for everything, right? We always send them. We always send a CBC and CMP for CBC. We definitely want to see that white blood cell count. We can see platelet counts. If we're bleeding, we can see that hemoglobin and hematocrit. And CMP is really good to assess our kidney function. We get all of our electrolytes. For acidotic, what electrolyte is commonly high when we're acidotic and our kidneys might be struggling a little bit? What electrolyte would we be worried about? Yeah, good job, Faith. Yeah, absolutely. We're worried about potassium. Yeah. So that CMP can tell us that potassium level. Absolutely. Okay, so let's kind of review here. We've got this patient, they had some sort of other infection. Sometimes they come into the hospital and they're already in sepsis, and we don't know what that original infection was. And that's when we're doing a lot of this lab analysis to figure out where's the source here. They're showing us all of these septic symptoms. They come in, they're hypotensive, they're tachycardic, they're not oxygenating well. We send off all these labs, they're acidotic, and they're painting the full picture of being septic. But we don't know, did they have a pneumonia? Did they have a UTI? We don't know. We've got to do some source analysis. But we need to stabilize this patient. So we are going to navigate treating sepsis in the form of bundles. And this is how the entire country handles this. Everybody's really aligned on how we handle sepsis because it's very common. And I shouldn't say it's really common. It's very common in critical care settings and it's very deadly. So there's been tons of research poured into it, and we're very consistent in how we handle sepsis. So that if you go work at one hospital and then you move to another one, like I've worked at many, you can count on your sepsis management being pretty consistent. So let's take a look at these bundles. We call these sepsis bundles. In the first 3 hours, when we first are suspecting that somebody has sepsis, we are going to draw some cultures before we get antibiotics. We don't want those antibiotics to mess with our blood cultures. So we'll draw cultures and then we'll start antibiotics. Those antibiotics that we start, are those going to be broad spectrum or narrow spectrum antibiotics? Yeah, they're going to be broad because we are sending cultures right now. We don't know what bacteria is hanging out in this blood. We want to kill anything and everything. Now, as we get those blood cultures back, hopefully in the next 12, 24, 36 hours, we will narrow those antibiotics in to whatever bacteria we find. So we'll start with broad antibiotics. We're going to draw a lactate. We want a baseline for what is the perfusion status. That's kind of what lactate is telling us. We know it's that byproduct of anaerobic metabolism. So how long have we been in anaerobic metabolism? How many tissues are operating in anaerobic metabolism, meaning they're not being perfused? That's going to tell us that lactate's going to give us a baseline for that. Fluid resuscitation. This is, again, a standard recommendation. 30 milliliters per kilogram for hypotension or if that lactate level is over 4. Typically, when we're suspecting sepsis, we're seeing that hypotension there, and we're going to give fluid. Remember, they had something called relative hypovolemia. Even though they haven't necessarily lost fluid, unless maybe they're bleeding or whatever's going on, they are so vasodilated that that toes is empty. So we're going to give some fluid, 30 milliliters per kilogram. It usually ends out to being a couple liters of fluid that we're going to give relatively quickly. So that's all in the first 3 hours. We want to have started antibiotics after sending cultures, get that initial baseline lactate level as well as probably all the other labs if you're there sticking them. And we are going to give fluid administration. Fluid resuscitation is less invasive than vasopressors. We don't want to use vasopressors unless we need them, and we know we need them if what didn't work. What would be our clue that we need vasopressors? If what did not work. Yeah, if the fluid did not work, if we're still hypotensive after giving 2 liters of fluid or however much volume it is for that patient, we are going to start some vasopressors. So we call that the 6 hour bundle, but it might happen before that. You could give your fluid resuscitation in 2 hours and determine it didn't work. Maybe we give a little bit extra, it's still not working. We're going to add on some vasopressors. Can someone tell me the vasopressor that we give for sepsis? First line. Yeah. Not dopamine. Yeah, good job, Juan. Vanessa. Norepinephrine. Norepinephrine or Levophed is going to be our first line vasopressor for septic shock. Dopamine is going to work primarily on the heart to increase its contractility. And that's usually not our problem in sepsis. Our heart's actually doing okay. What we need is to vasoconstrict those blood vessels, and norepinephrine is going to do that. Now, I will say norepinephrine also does act on the heart, but not as much as dopamine. It'll give it a little bit of squeeze, a little bit of heart rate, but it's mainly acting on those blood vessels to vasoconstrict them, which is what we need in this vasodilation state. Desmopressin or vasopressin, really, we could add as a second line. That Levophed, if we're maxing out the dose on Levophed and our blood pressure is still low, we might add vasopressin. Then we might add epinephrine. And we can, I mean, I've seen people on 4 or 5 different vasopressor drips. At 6 hours, we're going to remeasure lactate. We usually send off lactate every 6 hours. It's usually a good time to tell what effect our interventions have had. So let's look at that lactate. If it's remaining high, we might evaluate the need for further fluid resuscitation. Because that lactate is an acid, we can sometimes give a little bit more fluid to help the kidneys flush that lactate out as we are assuming that they have a adequate blood pressure. If they have an adequate blood pressure, that lactic acid should start to come down because we're now perfusing the tissues, right? We're ideally not operating in anaerobic metabolism. Now, over the next 24 hours, we're going to continue to manage this patient. We might start a corticosteroid. Now, why would we do that? Why in a septic patient would we start a corticosteroid? Yeah. All about inflammation, right? This is sepsis is when inflammation has gone too far and we want to shut it down. So we know that corticosteroids have those anti-inflammatory properties. Perfect example to use it. Now, we don't love giving steroids to our patients. So if we can avoid it, not every single septic patient is going to need a corticosteroid. Sometimes we can find the sepsis soon enough, start to manage it, get them some fluid, get antibiotics started to get that infection taken care of, and that inflammation will slow down on its own, but not every single time. And that's when we need to start a corticosteroid. Again, we're working on source investigation. We knew we sent blood cultures there in the beginning, but if they come back kind of inconclusive, we can't figure out where that infection came from, we're continuing to do source investigation. Avoid hyperglycemia. Why do we want to avoid hyperglycemia? What does sugar love? Or I should say, blank loves sugar. Yeah, bacteria loves sugar. And yes, somebody said side effects of the steroid. Absolutely. We can be causing some hyperglycemia by being on a steroid. Very good point. But yeah, that things do not heal in a hyperglycemic environment. Absolutely. If you take care of patients post-operatively, we always keep a really tight control on blood sugar because those surgical wounds are not going to heal properly. Really quickly, somebody just asked, what type of fluid resuscitation are we going to give for this patient? And that's a really good question. What do we think? Hypertonic, isotonic, hypotonic? Yeah, isotonic. Now, is there a preference? Do we think LR or normal saline? Kind of a trick question. It really depends. That is something that does vary hospital hospital. I will say, in my experience, I've definitely seen normal saline the most, but we can sometimes go too far with normal saline and we want to bring in some LR. It's very provider dependent, but isotonic being the most important. So it might be normal saline, it might be lactated ringers. Really good question. Okay, assess antibiotic therapy. That's basically saying, if we got a culture back, do we need to switch up our antibiotics? Administer stress ulcer and DVT prophylaxis. This really goes for any critical patient. We are going to be concerned for stress ulcers because we now know that their body is under what? If they're fighting sepsis, are they prone to stress? Yeah, totally. So that means they're absolutely prone to a stress ulcer. So we're going to add on some stress ulcer prevention. Um, DVT prophylaxis, we know that this patient's no longer, running a mile outside. They're going to be more bedridden. They're just at more risk for those DVTs. Oxygenation, absolutely. So you don't really see oxygenation on this list, and it doesn't mean that it's ignored. It just means that it's very patient dependent. If this person came in and they were coming in with a pneumonia that got out of control and led to a systemic infection, then then we would potentially need to intubate them. They would maybe need to be on mechanical ventilation because they've got a lot of fluid in their lungs. But if this person came in with cellulitis and got a bloodstream infection, then they might not necessarily need oxygenation. So it's totally patient dependent. Low GCS is absolutely another reason. If we're finding that someone's really confused, altered mental status, we're worried about them protecting their own airway, then that could be a reason to intubate them, or provide some sort of mechanical ventilation. So it's very, very patient dependent. Um, one of the answers to questions says start the antibiotic and then do blood work. Um, if it wasn't specific about what that blood work was, then maybe um, they would say, yeah, start the antibiotic. But if it's a culture, um, we will definitely do the cultures before starting antibiotics. So if the question said that, then that question might not have been correct. Leave us a feedback and we'll fix it. Okay, so those are our bundles. Really good questions, you guys. You're asking perfect, perfect questions. So really quickly, because I know we're kind of out of time, this was a really great discussion. Let's just break down septic shock. All septic shock is, it's a form of distributive shock, meaning vasodilations occurring, which we know that because we've got massive examples. Um, so yes, two samples before starting antibiotics. Yes, typically we'll have two blood culture samples before, like one from one arm, one from the other. So we know a lot that's already on this slide. We know about septic shock. All septic shock is that differs it from sepsis is when we have that persistent hypotension. Um, when we notice that systemic inflammation, that vasodilation, blood pressure is kind of soft, but we give some fluid and the patient responds really well and they don't continue to worsen, we would call that sepsis. Now, if they continue to worsen and that vasodilation is massive and that hypotension is persistent to the point of needing those vasopressors, we're now calling that septic shock. So like I said, we've got this infectious source that leads to an inflammatory response, massive vasodilation, and increased capillary permeability. I cannot I cannot push this enough. When you think inflammation, I want those two things to pop in your head. Vasodilation and increased capillary permeability, because it tells you a lot about what's going on in sepsis. And then when you start to think about some other really critical conditions like ARDS, acute respiratory disease syndrome, you can really break down the pathophysiology of that as well by understanding inflammation. Etiologic factors, infection. Again, bacteremia is typically present, bacteria in the blood. Assessment, we know this, hypotension, tachycardia, and we see those infectious symptoms like fever. Diagnosis, do we have a positive culture or symptoms of infection? And that hemodynamic instability, that's what tells us we're truly in septic shock. Medical management, again, we just talked about this. IV fluid resuscitation, antibiotic or antiviral, antifungal therapy, if that's what's going on. Vasopressor support if we need it. And again, anything in these sepsis bundles. This is how we're going to manage septic shock. All about perfusion. We want to increase that blood pressure and increase perfusion. Okay, I know I went a little bit over. Are there any questions? I know that was really fast. Sepsis is a in-depth topic for sure, but my goal was to talk about inflammation, how we've got now that massive inflammation leading to vasodilation and increased capillary permeability. So we're losing fluid into the tissues. We've got that endothelial damage leading us to risk for DIC, clotting and bleeding happening at the same time. And that vasodilation ultimately is going to lead to hypotension and lower perfusion. We're going to try to fix this first with fluid and antibiotics. If it doesn't work, we're going to start some vasopressors to get some perfusion on board. Okay, any questions I can answer? Oh, you're welcome. I'm so glad. Yay, it's all coming together. Awesome. Common broad spectrum antibiotic given to patients suspected to sepsis. Um, Zosyn. Zosyn's a good one. Um, I want to say vancomycin, but I could be wrong about that. Um, I'm trying to think about ones I've given in practice. Cefepime, I think, is a little bit more narrow. So yeah, I would say, yeah, cefuroxime is another good one. Cefazolin, potentially. Sometimes they have some sort of guess. You know, if we have some sort of guess over what the source is, then they will. It's not like they're making the antibiotic narrow prior to cultures, but it's a little bit narrower if we kind of have some idea. But vancomycin, I feel like I give all the time. Um, okay, really quickly. Can we give epinephrine to a sepsis client or is norepinephrine? You're always going to start with norepinephrine unless there's something going on cardiac wise that we're concerned about. Norepinephrine is our first line for sepsis management. Absolutely. Really quickly, here is a survey, you guys. We are here at Archer, we are constantly changing things. We're constantly making new products, trying to meet the student where you're at. We want to meet you where you're at. So we have this survey here. We would love for you um to fill this out. I'll put it in the chat as well. And I think it's like 4 or 5 questions, and it really just tells us like what you're looking for from NCLEX preparation material. It should take 30 seconds, and it just gives us a little bit of insight into, yeah, again, what you're looking for and what you're thinking as you're going about looking for NCLEX material. Archer Review has a lot of different products out there to try to help prepare you for the NCLEX. QBanks, on-demand videos covering every bit of content you can expect to see on the NCLEX, as well as live reviews, 3-day live reviews. There's tutoring sessions. There's so much out there to try to, again, meet you where you're at. What's your learning style? What works best for you? And we really try to meet every student with their various needs. Sometimes, everyone has a different learning style. So please take a minute and fill out that survey. It really helps us kind of see what people are needing. One question here, Cass, can I ask the main difference between epinephrine and norepinephrine? Yes, I love this question. So I won't go too far into it, but norepinephrine and epinephrine, they naturally occur in our bodies, right? What is it, the parasympathetic nervous system or the sympathetic nervous system that we see norepinephrine and epinephrine released? Yeah, the sympathetic fight or flight nervous system, right? We're releasing those catecholamines of norepinephrine and epinephrine. Now, when they're released, they're going to act on what are called adrenergic receptors. Adrenergic receptors are our alpha and our beta receptors, and these exist throughout the body. Alpha receptors exist in the blood vessels, and they are going to, when they're stimulated, when they're hit by that norepinephrine and epinephrine, it's going to lead to vasoconstriction. And we just talked about how vasoconstriction is going to increase our blood pressure. So that's what alpha receptors do. Oh, I just gave myself a thumbs up. Um, that's what alpha receptors do. Beta receptors, beta 1 specifically, I'll focus on beta 1, is going to act on the heart. And it's going to say, heart, we need more. We're running from a bear. We need more cardiac output. So increase your contractility and increase your heart rate. Epinephrine is going to act more on that beta. It's going to cause more beta receptor activity. So it's going to increase our contractility, increase our heart rate, and it does a little bit on alpha 1 as well. Now, norepinephrine is the opposite. Norepinephrine is going to work primarily on those alpha receptors, causing that vasoconstriction, which is great in sepsis because that's our problem. It's a vasodilation problem. It's also going to act just a little bit on beta, but it's much less than epinephrine. So they're working on the same receptors, but they work on them in different strengths. Somebody asked, beta 2 works on lungs? Absolutely. Beta 2 provides bronchodilation, which is also important in fight or flight, right? That gives us a little bit more air. The way I differentiate beta 1 and beta 2 is we've got one heart and two lungs. So beta 1's working on the heart, beta 2 is working on the lungs. Alpha, if you think about this symbol, like it's not Greek, but the symbol for alpha, it kind of looks like a fish. And I think of a fish swimming in a river, and that river is our blood vessels. So that's how I remember that alpha is about blood vessels and vasoconstriction, and beta 1 is about that heart. That's how we can kind of differentiate some of our pressors because they do get really, really muddled. If you go into critical care, reach out to me. I'd love to talk more about it. Okay. All right, everyone, please take this survey. Thank you so much. Yeah, that's good too. Thank you so much for being here today, and we will see you in a future webinar.